had problems with trying to get obstacles through the controversial nature of some of, well, just work in autism, work in GI issues. And, you know, I'm always very, you know, appreciative of just how clear they've been in the fact that this is very important work to get on with and to do and actually go out and do it. So I both think that they're amazing. So anyway, thank you.
You can go ahead and screen share.
Okay, here we go. I had to find it. Okay, can you all hear me and see me?
Yes.
Okay, great. Paul, I want to thank you so much for that wonderful introduction, and just to reciprocate your work. I didn't know that you were a postdoc at the time of those early publications. I thought you were already an established expert. But when I was just beginning working with these children about 20 years ago, it was your work on the slides, some of which you've shown today, that really gave me the foundation and the basis to move forward with what otherwise would have been a very difficult work. So I want to thank you for that, and thank you for allowing me to pick your brain over the years. And now we'll get on with clinically relevant information that has evolved from Paul and others' work on the gastrointestinal tract of children with ASD and chronic GI symptoms. So what we've done over the years, and other groups have done over the years, is to identify and characterize the nature of the inflammatory bowel disease. But to date, and one of the panelists asked the question, you know, do TNF-alpha antagonists, do they help treat ASD inflammation? And the answer is a resounding yes, and we're going to get to that. But until now, no one has demonstrated the effectiveness of any medication on ASD GI inflammation. I've been treating it for years with a recent support for the Brain Foundation. Dr. Walker and myself have began putting together data, treatment data, to show, well, we're going to show you about that in just a second, to bring it into more of a clinical realm. So for those of you who are a bit weary of the scientific slides, we're going to show you some more clinical slides, and then Dr. Walker will follow me with the stats and the data, and back to the science. Is that a better view?
No, the other one was.
The other one was? Okay.
This is good.
Okay, very good. Okay, so what we've termed the inflammation of the gastrointestinal tract in children with ASD and chronic GI symptoms. It begins clinically. It begins with having a child with ASD, and the confirmatory tests are in the realm of behavioral pediatricians. We're not going to get through. We're not going to go through that now. But as far as having GI symptoms, patients that appear in my clinic have an established diagnosis of ASD and a constellation of symptoms, and they can include any or all of the following: diarrhea, constipation, abdominal pain, failure to thrive, weight loss, vomiting, food refusal, episodic food refusal, where they won't eat for a day or two, and then they will eat, and they won't eat for a day or two. Abnormal stools, in general, very malodorous, strange color, and food intolerances. And other lectures I've gone through that in slides where they look like. But when a parent sees this, or a caregiver sees any of these symptoms, in a child with ASD, those are the symptoms that mandate a clinical evaluation. And as you see on the bottom, parents frequently report that the GI symptoms that these kids have, the constipation, the abdominal pain in particular, those impact the quality of life of the child and the family unit more than the autism and the behavioral abnormalities of autism. And that's a very striking thing for a parent to say.
Excuse me, did you want to turn on your video?
Okay, there we go. Thank you. Okay, so the diagnosis of an autism-associated enterocolitis, and in a moment we're going to go through why we call it autism-associated, what distinguishes the inflammation that we've been speaking about and that Paul spoke about, what distinguishes this GI inflammation in autism from Crohn's disease or from other GI inflammatory conditions. And we're going to get to that, because those were the topics of previous papers of myself and Dr. Walker. But how do you make a diagnosis? So when you have a patient with ASD and with have chronic GI symptoms mentioned above, you can see that they grossly at colonoscopy, you'll see, these are both pictures of an abnormal colon. Normally it should all be pink. You should normally see blood vessels like you see there. Those should be numerous blood vessels. And here we see really it's a light red, not pink, and it's also absent of any vascular markings. Here you see it's less involved. There's more pink, there's patches of red, some blood vessels. On biopsy, you'll see areas of chronic inflammation. You'll see crypt branching, both of which are seen in Crohn's disease, neither of which are diagnostic or specific for any particular the inflammatory disease of the intestine, but it's commonly seen, and most commonly seen in Crohn's disease, and it's commonly seen, very commonly seen in the autistic children as well. When we go during the colonoscopy, if we advance the scope a bit further, as you saw in the previous lecture, you see terminal ileum, which is the last segment of the small bowel, and you see a very marked proliferation of lymphoid nodules, which in and of itself is not inflammation. It does contain B and T cells and other cellular subtypes that are inflammatory, but on biopsy, we know from a clinical standpoint that this is something which needs to be treated because you have what's called ileitis, when these white blood cells infiltrate the epithelium of the colonic crypt. So these are all findings that we often that we see to make the diagnosis, the gross endoscopic diagnosis, and also the histologic diagnosis. When we do an upper endoscopy, I can see the esophagus, you can see the stomach, and the first few inches of the small bowel. When you do a colonoscopy, you can see the entire colon, and you can also visualize the last few inches of the ileum. But there's between 9 and 10 feet to 13 to 14 feet of small bowel that's all coiled up, that's not accessible to the scopes. Capsule endoscopy, or known as the PillCam, which many of you are not familiar with, is able to visualize this small bowel. It takes 8 photographs per second for a total of 8 hours. And when we examine those videos, we will see aphthous ulcerations of the jejunum. Here we see the more typical ulcerations or erosions or inflammation is this one, where it's not quite an ulceration that has exudate coming out like you see here in these photos, but it's more of an area of erythema surrounded by an area that has some mild lymphoid hyperplasia. This is what we see in the small bowel at capsule endoscopy. Overall, without going into it, other speakers have, there's definitely strong clinical cellular and molecular evidence that ASD enterocolitis is distinct from Crohn's disease, but there's also a significant clinical cellular and molecular overlap between the two disease entities. So You saw some of those slides in Dr. Ashwood's lecture about how on the cytokine level, the cytokines, both intraepithelial and also systemic, are raised above the level of normal non-ASD children, but don't quite reach the level of children with without ASD and with Crohn's disease. What we did a number of years ago to demonstrate this is to do a PCA of the plotting of the ileum and also of the colon. This slide is of the ileum, where we have the Crohn's patients in blue, the healthy non-ASD, non-GI symptomatic patients in green, the ulcerative colitis, non-autism patients in this olive color, and the ASD patients in purple. And as you can see, the ASD has a clear overlap from a transcriptome point of view. It has a clear overlap with Crohn's disease. There's also a subset of the ASD and enterocolitis patients who are kind of off on their own, and then there's only minimal, statistically insignificant mixture with patients who were healthy. So this provides the molecular evidence from a gene transcript level of a different yet very similar transcript profile of the ASD and enteritis of the ileum. And here you see of the colon, it's almost an exact replica of what we saw on the ileum. We have the healthy patients without autism, without GI disease. We have the Crohn's patients in blue. We have the ASD patients in purple, many of which overlap with the Crohn's patients, some of which are off on their own. And again, so we're dealing with a disease that's similar yet somewhat different than Crohn's disease. The immunopathologic nature of ASD and enterocolitis and ASD is well established, and Dr. Ashwood went through those and other speakers as well. And as an inflammatory disease of the bowel, it is therefore logical, and this goes back to the question that one of the panelists asked. It becomes logical at that point as a clinician. What do you do with these patients? I have a patient who doesn't have what appears to be Crohn's disease, but clearly has inflammation of the gastrointestinal tract, and more importantly, he has severe GI symptoms. So what do you do with that? So up until now, because of the supportive nature of so many of the studies and slides that you've seen today, I've been treating them as we treat Crohn's disease in general. And that's with any sort of combination of immunomodulators, corticosteroids, immunosuppressants, anti-inflammatories, or biologic agents, and also diet. Diet ends up being extremely important. And that's perhaps a great topic for another time. So our experience has been that as we treat this GI enterocolitis in autism, and you see improvement in their GI symptoms, their abdominal pain, their diarrhea, their constipation, their failure to thrive, as we see improvement in those GI symptoms, that we do see improvement in those symptoms with administration of the Crohn's disease pharmaceutical agents. But together with that, the experience has also been that we see improvement in their behavior and cognition. And that the two seemed, over the years in my experience, the two have seemed to go together. Now, when you get a GI, the expected GI inflammatory improvement with the medications that we know help in Crohn's disease, to our surprise, we also were seeing improvements, parents were reporting improvements in behavior and even cognition. And that was, of course, unexpected. Both of these observations have yet to be scientifically demonstrated. And the Brain Foundation has very generously funded a study to look exactly at that. And the study is designed to determine whether The GI symptoms improve with standard IBD therapy, where the cognition and behavior improves in tandem with the improvement in the underlying bowel inflammation, and also the nature of the relationship between the GI symptom improvement and cognitive and behavioral. They're very interesting. Each patient is unique, and sometimes you'll see the degree of in tandem that you see the improvement will vary, and then you have to go back and wonder exactly what's happening. And that's been very instructive with so many patients over the years. And most importantly, if this correlation can in fact be statistically, mathematically, and scientifically established, meaning the association between improvement in GI symptoms and cognition and behavior, then one could say that treating underlying GI disease is an additional way to decrease the symptoms, improve the functionality of autism. And of course, that's very exciting. Briefly, the study design, we did 20 prospective first-time ASD enterocolitis patients, meaning patients who have a diagnosis of ASD and that on biopsy or endoscopy or capsule endoscopy have been shown to have enterocolitis, and treat them the way we normally would treat Crohn's patients, so no different than we had been doing for years. And the outcome measures would be, number one, improvement in the GI symptoms as a primary outcome measure, and a secondary outcome measure would be improvements in behavior and cognition. Just very quickly, I'm coming to the end. The challenge here was to create a GI questionnaire that was autism appropriate. The existing GI questionnaires that we use in academia are some of which are designed to measure objective GI symptoms like stool frequency, stool texture, etc. But many are also, many of the questions in standard questionnaires are asking the patient to tell them about specific feelings, levels of pain, intensity, location, frequency, etc. And that, of course, we wouldn't be able to know from patients who are poorly communicative. So the questionnaire was designed based upon our experience of how our patients over the years have manifested GI symptoms in a behavioral fashion. And by definition, the questionnaires have not been validated. They've been validated by our experience over the years. One thing I can say is that, and the validation work of the questions, I think will end up leaving to someone else in the future. But the first step in validating them is to see that if in fact the answers, responses to questionnaires pre and post treatment, I mean, initially and then over the course of a year, if those or many of those behaviors that we think are actually manifestations of GI symptoms, if they get better in tandem with the actual GI symptoms, the stool frequency, that's the first important step to the process of validating the questionnaire. And with that, I'm going to pass the baton over to my good friend and colleague, Dr. Walker.
So Arthur, I think you need to turn your screen off, and then maybe Paul, let me start sharing.
I think it says the assessment of impact of standard care. That seems to be out there, ready to share.
Yes, but that's
there we go. There we go.
Oh, that's yours. Okay.
Okay. There we go.
You should be able to try and, yeah, there you go. Great.
Okay. Are we good to go? Okay, good. All right. Let me get this view straightened out here. Well, okay. So I've been working with Arthur now for going on almost 20 years, and I've known Paul almost as long. And I'm a non-clinician, but I've been interested in this question about the GI impact on autism and behaviors and so forth. And in the course of meetings now for the last many years, we hear a lot of anecdotal information about how if children are treated for their chronic GI symptoms, not only the GI symptoms improve, but also the ASD cognition and behaviors sometimes improve, and sometimes dramatically. But up to the point where we began this study, I believe most of this information was anecdotal. And so it was difficult to get a handle on exactly. And the question I'd ask Arthur over the years many, many times is, of all your patients, and now we have bank samples from 1,500 patients, the question I had was, who gets better and by how much? And so what we're going to do in this part of the talk is just present to you some of the compiled data from the first phase of this treatment study. So the research question is, as Arthur pointed out, does treating the ASD-associated IBD by standard of care treatment, much like you would treat someone with Crohn's disease, that is with corticosteroids and non-steroidal agents, immunomodulators, and all this is clinically warranted, does it result in improvement, number one, in GI symptoms, and number two, as an ancillary benefit, does it improve cognition and behavior in these children? Okay, so the study design, which Arthur sort of alluded to, the first step is to have histologic or endoscopic confirmation of this enterocolitis in the new patient and a GI symptomatic child with a confirmed diagnosis of autism. And then treatment, as we pointed out, with induction steroids followed by additional agents as clinically warranted. And then finally, the final step is to evaluate all along the way, both at baseline and at multiple time points throughout the course of treatment. So longitudinal data for 12 months from patient-filled questionnaires that assess both the GI symptoms and behaviors, as well as the ASD symptoms and behaviors. And so, as you can see from the chart on the right, the GI symptom questionnaires, there are two of them, and these were developed by Dr. Krigsman. And we have named these the GISS, so that's Gastrointestinal Symptom Survey. And the first questionnaire is Bowel Movement Chart Survey, and the second is Externalizing GI Behaviors Survey. So at each time point, baseline and weekly, believe it or not, for 52 weeks, the parents would fill out these two questionnaires on their child who was being treated by Dr. Krigsman. And then to look at features of ASD to determine whether there was improvement, we used three of the standardized questionnaires, the Aberrant Behavior Checklist, the ABC, the Social Responsiveness Scale, and the Vineland. And so the Aberrant Behavior Checklist was assessed at baseline and then at 3, 6, 9, and 12 months. The SRS was assessed at baseline at 6 months and then at the completion at 24 months, or sorry, 12 months. And then the Vineland was at the beginning and at 12 months. So just to recap, the gastrointestinal related questionnaires, these are the primary outcome measures. Do GI symptoms improve? And to measure this, we looked at these two questionnaires that I just described, and then three of the autism related questionnaires. And so what I'll present next is data compiled from actually going through all the answers on these questionnaires. So the GI questionnaire data, at this time, at the time that we did the data analysis, which was very recently, 11 participants, and Dr. Krigsman mentioned our goal was 20, or maybe even as many as 30. There is some dropout rate and so on. But we've had 11 participants now that we have data from baseline all the way out to 52 weeks. Now, that's not to imply every person filled out every single questionnaire, but we have a massive amount of data. So we have, for this analysis, 426 individual bowel movement chart questionnaires that were scored for this analysis. And we used the non-parametric Wilcoxon sign rank test to compare the data between time points. And this is a statistical test that measures paired data sets. So in this case, we're looking at 2 time points. It's baseline and then some subsequent time point, whether it's 3, 6, 9, or 12 months later. And then in every case, a P of 0.05, less than or equal to 0.05, was considered statistically significant improvement. And so the GISS bowel movement chart questionnaire, the first of the two questionnaires, consists of 17 questions. And to do the analysis, we categorize these in 5 different groups. So the first group of questions, 1 through 5, assess the stooling behaviors such as bending forward, screaming, overt straining, hyperactivity during stooling, and so on. The second set of questions, 6 through 8, we're actually characterizing the stool itself. Questions 9 through 15 are all assessed frequency between 0 and 7 days of how frequently have a bowel movement and so on. Question 16 was the Bristol stool chart, and then question 17 was another stool characteristic data point. And so you're going to see a lot of these plots in the following slides. So we'll start here. This is the analysis of questions 1 through 5 in stooling behaviors. Now, recall that for these GI questionnaires, we looked over 52 weeks. And so for some of these patients, we actually had 52 data points. For others, we had fewer than 52, but we had a large data set for each of the 11 participants. And so it would be unwieldy to present all that information here. So what we did is look at baseline, which is time point 0 on the x-axis, and then 12, 24, 36, and 52 weeks. So in other words, the questionnaire that was filled at those time points. And that will give you a very fair idea of what the trends are throughout the year. And so on the left-hand, the y-axis is the score. We set the questionnaires up so that they could be scored easily from 0 to some number. And in all instances of the slides that you'll see for these GI questionnaires, a higher number means you have a worse condition, if you will, and a lower number indicates improvement. So what you hopefully can see from this, between week 0 and 12, so after 3 months, there was significant improvement. A single asterisk at the top that signifies the comparison. A single asterisk indicates a P of 0.5. 2 asterisks will indicate even more significant, a P of 0.01. So you'll see some of those along the way. So in this case, you can see between week 0 and 12 and week 0 and 36, there was significant improvement. And overall, the trend was that the stooling behaviors improved all the way out to 52 weeks. The plots on the right are actually the individual trajectories, so you can see how they look person to person. In the second set of questions, 6 through 8, these are the stool characteristics. There was significant improvement in stool characteristics at every time point that was compared back to baseline. Questions 9 through 15, frequency 0 to 7 days of specific events. No change, no significant change from week 0 out to week 52. And I'll point out here, but I'll point out again later, that we have 52 data points for most of these children, or 40 to 52 data points. So we could get more granular with the analysis, but right now, what I'm displaying for you is the overall trends. If we look at the composite score, so questions 1 through 15, now everything you just looked at, with the composite score in this case, there is only a significant difference between week 0 and 3 months out. As you can see from the plots here, there's trends. The trend is still holds that there's change and reduction in the score for most participants all the way out to 52 weeks, but it's not significant. But I would like to point out, so we have 11 patients. We're using a non-parametric test for which the indication is you really should have an N of 20 or more paired samples. And obviously in this case, we have 11. So we're a little bit underpowered in that way. And I want to show you, if you remove, there was one patient who was particularly refractory to treatment. So instead of trending downward the entire time, he trended upward, and in fact had a difference in score of about 20 from beginning to end. And as you can see on the y-axis, a difference in 20 in the wrong direction is a huge difference. And so if you remove, and so Dr. Krigsman told me this morning, that particular patient was so impacted at a later point in the study that he had to manually unimpact this patient. So it was a severe case, and he's now being treated again. But if you remove that one patient, so now we're looking at data from 10 instead of 11, you see a significant difference pretty much all the way across the board and all the way out to 52 weeks. So that's just to say that we believe that when we have an N of 20 patients to look at, or 30 patients, these data will be more believable, but I will say they're very encouraging, even with a small N of 11 patients. The Bristol stool chart, question number 16, it wasn't included in the composite analysis because it's sort of a separate entity. And for those of you that are not familiar with the stool chart, basically, I believe the wisdom is a type 3 to type 5 is relatively normal. Type 1 and 2 are more indicative of constipation, and 6 and 7 more indicative of diarrhea. But what you can see from the chart here is that between baseline and week 52, as a group, the patients improved significantly in a reduction from about 4.5 down to 3.5 composite score. Okay, so the second GI questionnaire measured externalizing GI behaviors. And this is one of the aspects that makes the questionnaires that were generated by Dr. Krigsman so unique, because you don't pick up these types of questions in the standard pediatric GI questionnaires that are currently in use. And so he designed these that ask questions in a way that's very specific to this particular population, because they have very specific behaviors unique to kids with autism. So again, same 11 participants. In this case, we scored 450 individual questionnaires and used the same statistics and the same significance parameters. This questionnaire, there are 3 subscales. The first subscale measures physical and behavioral signs, and that's the bulk of the questionnaire, 19 questions. The second subscale looks at extremes of behaviors, 8 questions there. And then the final subscale, it's a single question, 2 parts that ask about abdominal pain and do you have it, and how intense is it? And so if we look at the change over the course of the study for physical and behavioral signs, you can plainly see that there was a highly significant improvement from baseline to 52 weeks and at every time point in between for these 11 patients in terms of physical and behavioral signs. The extremes of behavior were significantly improved up to 36 weeks and still trending towards improvement, but you can see just looking at the plot on the left or the right, there's one time point at 52, or there's one patient data point at 52 that's way outside, it's an outlier in other words, so that's one that did not improve. That's the same patient from the other symptom surveys, but we kept that in for this. If you look at abdominal pain, significant improvement at every time point compared to baseline in the 11 patients. And again, these are comparing the individual patient data point at baseline to that same patient's data point at a later time. And we're looking at trends across the group. We're not specifically saying this patient or that patient got better at every time point or worse at every time point. It's a cumulative. As a group, there was improvement in the 11 patients. And then finally, if you look at the composite scores for the gastrointestinal symptoms, both questionnaires, there was significant improvement across the board in these 11 patients. If you look at the ASD questionnaire data, it was the same 11 participants. This time there are fewer questionnaires because, as you recall, we did the ABC questionnaires. The parents filled those out at 5 time points, so baseline, 3, 6, 9, and 12 months. So we had 50 individual ABC questionnaires. The SRS was filled out at baseline, 6 months and 52 weeks, so at the end of the study. So there were 31 of those, and then 22 individual, once at baseline and once at completion of the study, VABs. And same statistical test used and the same parameters. For the aberrant behavior checklist, the ABC scores, there was significant change, improvement from baseline to 24 weeks and also from baseline to 52 weeks. So the trend across the board was improvement and significant improvement in the ABC scores. The composite scores for the SRS, looking at 0 to 24 weeks, there was a significant reduction in the social responsiveness scale score. However, this didn't hold to 52 weeks. So from baseline to 52 weeks, statistically, they were not different I will continue to remind you these are 11 patients. And so I think when we have a larger data set, that some of these differences may become more clear and statistically relevant. The Vineland Adaptive Behavior Scale, interestingly, the Vineland composite scores did not change from baseline to 52 weeks, much at all. However, there are two components of the Vineland that measure maladaptive behavior. So in the Vineland Adaptive Behavior Scale, a higher score means you've improved. In the maladaptive subscales that are optional, not everybody uses those. In the maladaptive behavior subscales, a lower score indicates improvement. So what we found, the maladaptive behavior internalizing, from week 0 to 52, there was significant improvement in the group. And also with maladaptive behavior externalizing, there was significant improvement across 52 weeks. And this actually tracks well and maybe provides some additional support for Dr. Krigsman's externalizing behavior GI questionnaire, because the two of those I would think would be highly correlated. And so in summary, the GI surveys showed pretty much significant improvement at every time point from baseline out to 52 weeks following and during and following treatment for GI symptoms. The data summary regarding the ASD characteristics, the ABC composite scores improved across the time. The SRS did not. And the VABs did not improve as a composite, the adaptive behaviors, but in both cases of the maladaptive behavior, there was improvement at 52 weeks. And so I guess the key takeaways that we would like you to have from this are, first of all, these are preliminary results, but they demonstrate significant improvements in both GI and ASD symptoms and behaviors during and following 1 year of treatment for ASD-associated enterocolitis. As one would expect, the outcomes vary between individuals, both in the direction of change, whether it's positive or negative, and the magnitude. And if you've been listening at all over the last many years about the clinicians talking about treating children with GI symptoms and autism, this would not surprise you at all, because some children, even Dr. Krigsman's experience, continue to be refractory. These are not, by and large, easy cases. These are hard cases. That's why it takes people like him who have been at it for 20 years to have success, because you have to keep at it and you have to have a deep understanding of what you're looking at here. So the final takeaway, I believe, is we believe at the individual patient level, we have a lot of interview data here. And so a more granular look at what these symptom questionnaires are telling us, both based on the GI symptoms and the specific ASD individual domain data for these three questionnaires, in the context of the clinical picture at the times at which the questionnaires are being administered, may provide, during the course of treatment, important new details and inform the ongoing treatment strategy. Be helpful, in other words. And so finally, I can't leave without giving kudos and great thanks to Peyton Lee, my clinical studies coordinator, and Dylan Wolf, who's a first-year resident in my group. They were a terrific help in getting these data compiled. And with that, I'll end.
Thanks, Stephen. Thanks, Arthur. I think we're running a little bit behind time. So if you have an opportunity to look at the Q&A and answer those questions there are several that have been posted. That would be fantastic. And I think we can move on to the next speaker, which is Dr. Alicia Fasano. And